Hello, good morning all. Today, our presentation will be about SLE, which is a very dangerous and very complicated rheumatic disease. So, we will have the definition, clinical manifestation, epidemiology, diagnosis, pathogenesis, mortality, and the therapeutic principles. So systemic lupus erythematosus, it is an inflammatory multisystem autoimmune disease of unknown etiology with clinical and laboratory manifestation and variable course of prognosis. Lupus can be mild disease, severe disease, and life-threatening illness, or anything in between. The clinical manifestation of SLE, it is important concept. The diversity of clinical symptoms in SLE is great, and all organ systems are vulnerable. Different ethnic background are associated with difference in disease prevalence and severity. Disease is characterized by period of a flare and remissions and can culminate in irreversible and end organ damage. The epidemiology. The prevalence is 2 in 140 over 100,000 worldwide, but as high as 207 in 100,000. The incidence is 1 to 10 worldwide. Population at highest risk, women in their productive years, females to males ratio is approximately 9 to 1. So it's most probably to be affected the females, and post puberty and premenopause due to hormonal imbalance that it will be at this period. Population at high risk, there is variation in the race and in the ethnicity, more common in blacks 3 to 6 times, Hispanics and Native Americans 2 to 3 times, and Asian 2 times of the populations. Every year there is a cost, there are direct costs associated with treatment, more than 100 billions in healthcare costs associated with autoimmune disease, especially in NSE and SLE, and indirect costs that related to loss of productivities from the patients or the females that they will be affected by the SLE. The American College of Rheumatology, which is a revised criteria for classifications, 4 out of 11, it is 95% specificity and 85% sensitivity. Uh, the criteria are the presence of those symptoms: malar rash, discoid rash, photosensitivity, oral ulcers, arthritis, serositis, glomerulonephritis, neurological disorders, seizure or psychosis, arthritis, and hematological disorders, which is immune-mediated hemolytic anemia, leukopenia, lymphopenia, thrombocytopenia, and even the presence of the antibodies, which is anti-nuclear antibodies, and immunological disorders like anti-DNA antibodies, anti-Smith antibodies, or anti-phospholipid antibodies. So the criteria will be having those symptoms plus the presence of the antibodies in the system. So as we saw in the picture that the lupus of the outside, it is either synovitis, malar rash, oral ulcers, subacute cutaneous lupus erythematosus, vasculitis, discoid rash, and lupus performance. So all those symptoms, it is extra manifestation or can be one of the types of the diagnosis. Also, we can find the pericardial effusion, cerebral infarction, glomerulonephritis in the cells, spherocytes, brain atrophies. This is from the inside, like in the body. If we have lupus, it will affect the organs itself inside the body, or extra manifestation, like we see in the skin, in the buccal mucosa, and even in the joints. There will be also, of course, the pain, the fatigue, the depression, the psychosis, the memory thief, like memory loss. All those things can be additional to the symptoms of the SLE. As we mentioned, it is organs that involves the central nervous system, oral, pericarditis, blood disorders, joint arthritis, muscles, kidney disease, pleurisy, skin, eyes. So it's affect all and each organs in the body due to the autoimmune deposition of the antibodies. Here we have a case presentation of 23 years old Hispanic female with no past medical history, presented to the emergency department with 8-week history of joint pain, swelling in the hands, knee, ankles, fever, myalgias, pleuritic chest pain, weight loss, and facial rash that worsened with sun exposure. She has been seen initially at the local clinic and treated as cellulitis because she's having those symptoms of the rash and it's increased with oral antibiotics. 2 days prior to the presentation, she was treating with oral antibiotics. 2 days prior to the presentation, she was seen in another emergency department found to have a temperature of 103 Fahrenheit, proteinuria, anemias. She was told it was a viral syndrome and discharged home. So there is two presentation complicated in this case. The first presentation, viral-like symptoms, and the other thing, the cellulitis, and both of them are misdiagnosed, like as simple thing and discharge. Her temperature was 37.9, blood pressure 130 over 90, painless ulceration of the palate, and there is erythematous malar rash, diffuse lymphadenopathy, and synovitis of the MCP and PIP joints. The white BCs, it was 2.5 thousand, total protein was 9, albumin 3, hemoglobin 11, hematocrit 32, PUN 11, and CR is 0.6, UA is 100 milligram per deciliter in protein, and RPCs 20 to 40, white PCs 0 to 1, and there is ANA positive and anti-double strand positive and SM positive. So the labs give us a different clue or idea regarding the diagnosis. So unless you suspect it and you do the workup properly, maybe you can miss, or the patients will come every time with different complaints in different systems. So what do all the lupus patients have in common? Anti-nuclear antibodies. There are multiple methods for detection, but immunofluorescence is the most reliable. In immunofluorescence, ANA assay, a serum sample is applied to a glass slide covered with fixed cell to allow access to nuclear antigens. The antigens antibody reaction is revealed by fluorochromes, conjugated anti-human immunoglobulin antibodies. That's why it is having 95 to 98 of SLE patients having the ANA bits present. So the slide is then examined by fluorescence microscope. So the ANA, it's an antibodies against various components of the cell's nucleus, presented in many autoimmune disorders as well as some healthy subjects. Sensitivity not specific for SLE because of low specificity. ANA and usefulness increased in the pre-test probability for lupus is high. So the patient has symptoms and signs that can be attributed to SLE. Because of the high sensitivity of the ANA, patient with negative ANA is unlikely to have lupus even when he or her or his clinical presentation is suggestive of lupus. So the incidence of positive ANA, normal subject 3% to 4%, SLE 95% to 99%, scleroderma 95%, Hashimoto thyroiditis 50%, idiopathic pulmonary fibrosis 50%, and the incidence increase with age, chronic infections, and other chronic conditions. Okay, there is pathogenic autoantibodies, anti-SSA and anti-SSP. There is subacute cutaneous lupus, neonatal lupus, and complete heart block in utero. So those all symptoms can be give us clue that there is complications of SLE. The autoantibodies in the SLE. We have plenty of antibodies that can detect the SLE, but there is some of them having a high specificity, non-specificity, and low specificity. So the ANA, it's non-specific. Anti-double-strand DNA, it is high, and clinical association with nephritis as well. Anti-SM, it is high, non-specific. The anti-RMP, it is low. It's mainly clinical association of arthritis, myositis, lung disease, and anti-SSA, it's low. It is a clinical manifestation or association with the dry eyes, mouth, subacute cutaneous lupus erythematosus, neonatal lupus, and photosensitivity. Anti-SSP, it is low specificity and same like the above antibodies. And antiphospholipids, it is intermediate and it is having a clinical association with a clotting disease. So the antibodies preclinical detection. The autoantibodies precede diagnosis by many years. Like we are currently not able to predict which subjects with positive autoantibodies titers will develop the disease. As we saw in this diagram that down there is the time and the patient with positive test by years, every time there is a sensitivity that there is a disease, but the diagnosis we reach it after plenty of years of deposition of the disease. So that's why the antibodies can give the preclinical detection. It is more giving us clue that we are going toward the SLE and we are having the antibodies reaching the diagnosis after plenty of years. So there are phases of the disease pathogenesis. The initiation, there is multiple proposed mechanism that may vary from patients to patients, occurs years prior to the onset of clinical symptoms. And then we have the amplification and the dysregulatory immune mechanism and response of target organs to inflammatory insults, irreversible damage from the disease, and secondary effect of the treatment. So it will not directly you have the disease and immediately you have irreversible damage. It is a gradual progress of the disease, gradual involvements in the systems. It depends from patient to patient and it's vary of course, but like the plateau of the disease itself, it will take a lot of times or plenty of times. So the causes of autoimmune disease are multifactorial. We have the genes, we have the environment, we have the behaviors, and all can increase the risk of having the SLE and other autoimmune disease. So in the environmental factors, we have the hormones like the estrogen, mainly the estrogen. That's why the disease it's increased in the premenopaused woman and in the productive age women because of the estrogen and hormonal imbalance. Infections, toxins, medications, sun exposure, and vitamin D deficiency. All those are environmental factors that can predispose it to have the SLE. In the behavioral sides, we have the smoking, sun exposure, stress, and toxins. So the toxins, the smoking, the antigens, the exposure to the sun, all can increase the risk. Either it is from behavioral or it is environmental. The results will be one, and it will increase the risk of having the SLE. Okay, this is in this paragraph, we have the initiation, amplification, and pre-fusion of the SLE. It is all about the abnormalities function of B cell, T cell, BDC. So the genetic alteration can result in B cells and T cells abnormalities. Environmental exposure can also predispose it to B cells and T cells disorientation. Also, we have the pre-inflammatory molecules and autoantibodies. All are cause the tissue injuries. So all those things, all those things can increase the susceptibility of having B cells and T cells dysfunctions, malregulations, and lead to tissue injury. Okay, examples of immune dysregulation in the lupus, like the B cells, it is defective selecting and signaling, and the autoantibodies production. So if we have any predisposition of the P cells, of course, it can make us having the autoantibodies deposition. T cells increase in numbers of T helper cell 17, and T helper 2 cells are decreased numbers of targets. T cells are less susceptible to activation-induced cell death. Plasmacytoid dendritic cells. It is produce large amount of interferons, and it is stimulate activation and proliferation of autoreactive T and B cells. So all of them, in direct or indirect ways, they will lead to deposition or auto reactivation of T cells and B cells, which is the main autoimmune cells in the body that can lead to any dysregulation, can lead to the SLE. The pathogens of lupus. The autoimmunity is an altered immune hemostasis and leads to autoreactivities, immunodeficiencies, and malignancies. Immune dysregulation leads to autoreactivity, and autoantibodies in SLE occur in different phases and likely represent the untoward effects of environmental triggers on the genetically susceptible host. So the environmental effects, smoking, like infections, like sun exposures, not all patients that are exposed to those risk factors can lead to have an SLE. Already the patients have a trigger or having dysregulation in the autoimmune or in the P and T lymphocytes. That's why the environment, it's a trigger the disease, it's trigger to have the symptoms and depositing in the and making those organs damaged. The disease activity. So SLE is characterized by period of a flare, increase in the disease activity, and remissions or low-level disease activities. It is varying the flare rate. Some of the patients having flare more than times in a month, and others more than times in a year. And there is a predictor of the flare in some patients, but not all the cases. We can predict that there is a flare is coming. New evidence of complement consumption, raising anti double-strand DNA titers, increase in the ESR, and new lymphopenia. All those clinical clues or like blood tests that can give us clue that we have a flare upcoming. It is characterized by abrupt onset of symptoms, increase in renal, neurological, hematological, cirrhosis involvement, rapid and crucial damage, irreversible organ damage or injuries, and it is associated with race and ethnicity, young age of onset, male gender, lower socioeconomic states. As we mentioned that the male to female ratio, it is 9 to 1. So having SLE in a male gender, it is increased the bad prognosis of the disease. And even if you have it in a younger age, so the disposition and the organ damage will be increased, and the prognosis will be more due to having the disease since long times. Even as we told that the race and ethnicity, Spanish, Asian, Native Americans population, and the blacks have the more susceptibility to have the bad prognosis of the disease. The mortality 5 survival rate in 1953 was 50%, and currently it is more than 90% due to the genetics test that it's done, to having the screening, due to that there is a biological treatments, due to a lot of change in the clinical examinations and histories. It is decreasing the mortalities rate in the SLE. Leading cause of mortalities are heart disease, malignancy, and infections. Factors contributing to increase the mortality. The disease duration increase the mortality early on. So as we mentioned that having the disease in younger age, it will increase the risk of having increase the mortality or the survival rate. So, disease duration increase the mortality early, high disease severity at diagnosis, younger age at diagnosis, ethnic like Black, Spanish, Native Americans, male genders, low socioeconomic, poor patients' adherence to the treatment or the follow-up, inadequate patient support system, limited the patient's educations, and it can miss the follow up or not coming when the flare is there, so it will decrease the survival rates. So the therapeutic principles for the disease. Goals of the therapy is stop and reverse ongoing organ inflammation, prevent or limit irreversible end organ damage. It is a chronic disease, and once it's diagnosed, so it's there. So we will try to stop and reverse the ongoing organ inflammations. Either it is vasculitis, cellulitis, whatever the organ that having inflammation, we will try to stop and reverse it, and we will prevent or eliminate the irreversible end organ damage like the kidney damage, nephritis, all those. It's manageable. We can treat the organ itself to avoid the organ damage. Potential toxicities of immunosuppressive therapies damage valiant management. Strategies used of targets immunobiological therapies based on pathogens mechanism with global immunosuppressions. So those are the current therapies in general for the SLEs, which is corticosteroids, cyclophosphamide, methotrexate, azathioprine, hydroxychloroquine. But here in this paragraph, the algorithm for treating of the targets in lupus, like targets the remission or low disease activities. There is mild, moderate, severe, and refractory. So in the mild, we will go for the glucocorticoids, either it's oral or IM or topical GC or methotrexate. In the moderate, we will go for the prednisolone orally up to 0.5 mg per kg per day, IM or IV, methotrexate, azathioprine, and cyclosporines. In the severe cases, we will increase the dose of the prednisolone from 0.5 to 1 mg per kg per day, and it will be through the, or it's in the IV. And we will add the tracroclemius. And the cyclosporin will be the same. In the refractory period, we will have the rituximab, pelimiximab, and also the IVIG. There are non-pharmacological treatments like the sun screening, stop smoking, healthy diet, exercise, vitamin D supplement, psychological supports. All those are non-pharmacological treatments. It's help to minimize the effect of the journey of having the disease, but it will not like treat the organ damage or all. Mainly the medications or the IV injections or the IVIG is the main treatment of this prognosis of the disease. So the limitation of those diseases nowadays, the immunosuppressive drugs confirm an increased risk of infection, cancer, and infertility. The common side effects of the corticosteroids, as we know, is infection, cushingoid appearance, osteoporosis, osteonecrosis, lipids abnormalities, hypertension, mood disturbance, and diabetes. Those are all the limitations of the immunosuppressants. We are treating patient having a disease affecting his whole life, and also they have the choice to decide exactly which medication they can use to minimize those side effects. So new therapeutic strategies target immunotherapy. It is immune targeted therapy, B cells directed, cytokines inhibitors, co-stimulation blockage, peptide inhibitors, kinase inhibitors, and T regulatory cells. As we say that we have the B cells and the T cells, the medication directly will go to target to target the therapy will be directly targeted the receptors itself. So, and even the stem cell transplant, it is all a new therapies strategies that will target the immunotherapy to increase the outcome of the disease and the beneficial of the immunosuppressant. So there is therapeutic strategies. Therapeutic combination aims to induction of remission, maintains therapy and supportive therapy. Teachers does to treat effectively with focus on involved organ and to minimize the toxicity, strategic use of preventive therapies, antibodies and antibiotics and vaccinations, cardiovascular screening, cancer screening, osteoporosis screenings. A part of the targeting treatment, also we have to screen for another involvement or the results of the like the complications or side effects of using the medications. So the lupus, in summary, it is a clinical disease characterized by symptom diversity, periods of flares and remissions. Pathogenesis is related to genetic susceptibility combined with environmental, behavioral triggers, immune dysregulation characterized by autoantibodies production. Treatment is targeted to clinical manifestations, treat the clinical manifestation, severity of the organs and organ system involvement, and managing the disease. So, in summary, a lot of SLE patients are coming to the emergencies or to GPs or to the clinics with symptoms like not at the beginning will come with the full story or the full history of having the disease. It will come with variable symptoms. So we have to keep in our mind that SLE can be detected by the antibodies. So if there is any suspicion of the SLE, it is better to start it first. If there is any genetic in the families of having SLE, it should increase the awareness of having the screenings and the clinics or in the emergencies, and don't diagnose the SLE or just treating the symptoms of the complications or the cellulitis or the joint pain without having a clear idea why it is having. This is